Thank you so much. After this inspiring talk, we will be discussing about testosterone. We will first focus on the physiology, which is something we all know, but it's always nice to remember the basics. Then male hypogonadism and what are the options we have. As you all know, testosterone is produced from Leydig cells under the regulation of luteinizing hormone. It's a cholesterol, so it's basically fat. Fat cannot circulate in our body freely, so it has to bond to something, mainly protein, called sex hormone binding globulin and albumin. Only 1 to 2% of testosterone is free. And this free testosterone is able to go through the cytoplasmic membrane and attach, do his magic in the nucleus, and that's how it shows its efficacy. Several clinical conditions can modify sex hormone binding globulin levels, so it's important to know them. Drugs, hyperthyroidism, hepatic diseases, aging, smoking, HIV, and AIDS condition can increase sex hormone binding globulin, and therefore the active form of testosterone can go low. However, on the other hand, hypothyroidism, obesity, several drugs, acromegaly, insulin resistance, non-alcoholic fatty liver disease can decrease sex hormone binding globulin, so free testosterone levels will be higher. Role of testosterone in male sexual and reproductive health includes sexual development and maturation during fetal life and puberty, and sexual function in the adolescent life. So, as you may remember from your embryology classes, we have a bipotential stage when we were a baby in the belly of our mothers, and then under the influence of testosterone, our vulva, vagina is closed, and the clitoris became enlarged, and that's how a penis is formed, and labia became scrotum, and that's how testosterone made us men. These are the images from embryology, and I find it quite fascinating. I mean, look how we are actually similar. There are some conditions which I also find quite interesting. Congenital adrenal hyperplasia, because congenital adrenal hyperplasia girls are having excessive amount of testosterone during their pubertal life, and they look like a man, and they are born with ambiguous genitalia, but actually they are 46XX, so they are genetically female, but they are being exposed to a lot of testosterone. And when you ask a 4-year-old girl to make a painting, because of not having testosterone, they are drawing ladies and flowers and butterflies, and the colors that they are choosing are mainly red, yellow, purple, and etc. When you ask a 4-year-old boy to make a drawing, they draw cars, trains, tanks, guns, moving objects, and the colors that they are preferring are dark brown, dark blue, black, gray. So apparently testosterone is not only affecting our genital development, it's also affecting our brains, and because of being exposed to too much testosterone in our embryonic life, we like moving objects, we like football, we like cars, we like fighting people, and that's what enjoys us the most. When you ask a girl, congenital adrenal hyperplasia at the age of 4, and when you ask her, I mean, she was corrected genitally under hormone replacement therapy and blah, blah, blah. No, those girls are again making drawings about guns, cars, trains, cars, and the colors that they are preferring are brown, black, gray, dark blue, and etc. So we cannot fix their brains, but that's what testosterone does us. Another interesting study, which I find quite fascinating, they put men and women under MRI, and they made them watch soft erotic movie, kissing, hugging, and etc. You see the brain of a man, no activity. Just a slight shining at the uncus area, very slow area. Look what happens to women. Women's brains are on fire. I mean, they enjoy what they are seeing. Then they switch the movie and they make them watch real hardcore porn, a lot of action. Now, male brain is on fire. I mean, they like what they are seeing because there's action. Female brain, just a little bit activity here. So testosterone is a must for our general health, but also our mental health, our sexuality, our erections, and for everything. We know that with aging, our testicular functions are going down, and our sperm production is also impaired. The incidence of male hypogonadism is approximately 12 cases per 1,000 people every year. In men between 40 to 79 years, the incidence varies between 2 to 5%, but nowadays we are acknowledging the fact that maybe we are underdiagnosing this male hypogonadism issue. We also know that type 2 diabetes, metabolic syndrome, obesity, cardiovascular diseases, obstructive pulmonary diseases, renal diseases, cancer, sleeping disorders, COVID, many things can decrease our testicular functions, and they may cause male hypogonadism. What are the symptoms of male hypogonadism? There are really specific symptoms such as reduced libido, erectile dysfunction, decreased spontaneous morning erections, decreased vigorous activity, difficulty walking, decreased bending, low mood, decreased motivation and fatigue. But also there are some less specific symptoms such as reduced frequency of sexual intercourse, delayed ejaculation, hot flushes, decreased energy, concentration, or mnemonic difficulties, sleep disturbances. So, as I said, testosterone is not only affecting our penis or sexual drive, it's also affecting our sleep, our concentration, our cognitive functions, many things. When we have a man complaining of those symptoms that I have mentioned, what we are supposed to do? Number one, we have to check whether there are any drugs, anything. Remember, sex hormone binding globulin, increasing drugs and decreasing drugs, medical conditions, which can interfere testosterone production. We need to check for concomitant metabolic diseases, especially obesity is a pandemic nowadays. Many people are obese, and there are some reports showing that those obesity medications, Mounjaro, Ozempic, are also decreasing testosterone, but we are not very much sure about it yet. Diabetes, and then we need to make a testosterone measurement. We need to measure testosterone between 8 to 11 in fasting conditions. This is very important because testosterone has a diurnal rhythm, as you can see here. At 8 in the morning, it is at its peak position. At 8 in the evening, it's in the deep position, and then it's increasing again. But in the aged population, it's consistently low, and we don't see this diurnal variation anymore. So it's important to measure it in the morning in the fasting state. Then, if testosterone is lesser than 12 nanomole, then we are supposed to repeat the testosterone because this man can have a flu, he may not be able to sleep properly, maybe he's in depression, anxiety, and etc. So we need to repeat it. If it is, again, lower than 12, then this guy is suffering from hypogonadism, and you are entitled to put him on testosterone replacement therapy. If it is greater than 12, then we can still consider if he is suffering from secondary hypogonadism or things like that. To remember the differences between primary hypogonadism and secondary hypogonadism. If there's a problem in the testicle, we are talking about primary hypogonadism. FSH and LH will be enhanced, and gonadotropin-releasing hormone also enhanced. And if there's a problem in the central nervous system, we are talking about secondary hypogonadism. So in these guys, LH, FSH will be low, and testosterone will be low. The causes of hypergonadotropic hypogonadism, in other words, primary hypogonadism, when there's a problem in testicle, congenital abnormalities such as Klinefelter syndrome, iatrogenic causes, testicular trauma, infection, and autoimmune damage, whereas secondary hypogonadism, in other words, hypogonadotropic hypogonadism, can be because of Kallmann syndrome, pituitary conditions, medications, hyperprolactinemia, prior head trauma, and severe chronic illnesses. If testosterone is lesser than 8 nanomoles, I mean, there's no need to repeat the test. Probably this guy is suffering from hypogonadism, so you can immediately put him on testosterone replacement therapy. There are some contraindications, which I will mention in the next slide, but you have to always ask if this guy is desiring fertility. If they want to father a child, testosterone replacement therapy is contraindicated, because when you give testosterone, FSH and LH will go down, and those guys will not have any spermatogenesis anymore, so he may suffer from infertility. Okay, what are the types of testosterone replacement therapy? There are pellets, gels, injections, and oral medications, but we have to remember the contraindications. The absolute contraindications are locally advanced or metastatic prostate cancer. We have some discussions about that. We may discuss it later. Male breast cancer, man with an active desire to have children, hematocrit greater than 54%, uncontrolled or poor controlled congestive heart failure. And relative contraindications are BPH, if IPSS score is greater than 19. There are some authors suggesting not to initiate testosterone replacement therapy, high baseline hematocrit levels, and familial history of venous thromboembolism. So, why we are doing this? Because we know that in hypogonadism, testosterone therapy can improve erectile dysfunction and libido, other sexual symptoms, body composition and insulin resistance, weight, waist circumference and lipid profile, mild depressive symptoms, and bone mineral density can all be improved among men who are using testosterone replacement therapy. There are other types of treatments for male hypogonadism. If a man is desiring fertility, and if a man is suffering from secondary hypogonadism, meaning that there's something wrong in his pituitary gland, then human chorionic gonadotropin, recombinant LH, recombinant FSH, all of them can be used. After 8 months or 12 months, the guy will have better testicular functions. It doesn't only mean that his testosterone levels will increase, but also his sperm production will start. There are also oral preparations which are not very popular because, remember what I said, it's a cholesterol. So when a guy takes the testosterone orally, when it is digested, it's going to the liver, and the portal system is eliminating 80% of them. The remaining 20% starts to circulating. They can be hepatotoxic. The patients are supposed to take a lot of medications every day, so it's not really suggested. Parenteral formulations are commonly used: testosterone, enantat, cypionat, propionat. Their cocktails combining all those esters are being used, and especially in the United States. I don't think we have it in Europe. Testosterone pellets are quite commonly used in the United States, and also transdermal preparations, gels, creams are used. Those patients are expected to put the cream on their shoulders every morning after shower, and they are not supposed to touch their female partners or daughters, because there are some case reports showing that hirsutism, body hair growth among the female partners or children of daughters of men who are using those gels and creams. But after prescription of testosterone replacement therapy, no matter what you are prescribing, you cannot send the patient home. The patient should come for 3 monthly and then yearly controls. And in those follow-up visits, you are supposed to check the symptoms, whether he is improving or no, body mass index, waist circumference, digital rectal examination, PSA, hematocrit, testosterone, lipid and glycemic profile, and you are expected to do DEXA for his bone mineral density yearly. Thank you so much.